Okay, everyone. I am here doing an interview with Carlee. Carlee gave a great presentation on osteoporosis earlier in the month, and we just wanted to catch all the questions that have been coming up following her presentation on what osteoporosis is, how you could manage some of your osteoporosis issues at SPC, and what screening, what type of programming we're going to have, and just some general questions that seem to come up over and over again. So, without further ado, here's an interview with Carlee and
I. Awesome.
So, you just had these presentation. Tell me all about it. How did it go?
I thought it went well. It seems like I got a lot of good feedback, and I was excited when I came to work on Monday and Braden was here and everyone was lifting more weight and asking about jumping. So that's good.
What were if you had to say like for the whole presentation, what were the biggest takeaways you wanted people to have?
I wanted people to understand that what they're already doing with programming is good and that there are ways to even do better. You're doing so much more than if you weren't coming in. So that was a big one. And then I really do think the fact that lifting heavier has been shown to be safe in an uninjured population. And then also that the jumping has such a profound effect on the hip. That's a really big deal, I think.
It's a big difference in what most people were going to be thinking. What is your biggest concern?
The hard landings. Yeah, just the impact to the joints. But I don't know if I'm super concerned, because the way we've laid it out for the programming is that the heel drops I'm not that concerned about. They feel jarring, but I guess we'll just have to see how they work out. I don't think it's that much load to the knee.
I totally agree with you. Like the jarring part was surprising. The heel drops I've used before for people with disc injury.
Yeah.
To like elicit a disc irritation. But the crazy part is if we screen people and we get to where they can tolerate the activity, the hard landing may be like one of the most effective ways to get the bone to have a response we want.
It's interesting too, like I wonder if there's a difference to do a hard landing to try to elicit disc pain in an exam setting versus people have done their whole warm up and a workout and they've got a lot of real good activation in their stabilizers. I wonder if the hard landing is even that provocative anymore.
Since we've talked about it, I don't think it will.
It makes sense to me that after you've activated your TA and worked your glutes and like warmed up, I don't think it will be as jarring to a disc.
Okay. Number one question then that I have gotten is how does somebody know that they have osteoporosis?
Basically, the DEXA scan. So I think sometimes people have a little bit of confusion between osteoarthritis and osteoporosis and pain and osteoporosis. And pain is not associated with osteoporosis. So sometimes people think they have pain, so then maybe they have osteoporosis, but that's not true. So basically you would go get a DEXA scan and look at your score. Like I said, though, also, apparently you can get a clinical diagnosis if you've had a fracture from just a fall. That shows that you're high risk. And so that can be like a clinical diagnosis.
Because we've heard of things like, so it's like an insufficiency fracture. If somebody has that, is that somebody has osteoporosis, or is that a different thing?
You know, I actually can't speak to that very well because in the literature, they call it a fragility fracture, which I don't know if an insufficiency fracture falls into the same range. In my mind, I think that if somebody has an insufficiency fracture, if somebody came in and we found an insufficiency fracture, I would tell them go get a DEXA scan. So that might be an answer. It's not a diagnostic fracture, but it raises my suspicion.
And then you had said a couple times, who's at greatest risk of developing osteoporosis again?
Postmenopausal women, by far.
Postmenopausal women.
Yeah. And then later in life, men over 70 start to show up too. But like, I think it's like 2/3 of the osteoporosis diagnoses around the world are postmenopausal women.
I found it really interesting because both of them are hormonal components. So you said one is more gradual
Yeah.
and the other one is more quick.
Yes.
So I did want to discuss that part a little bit. So what's the
Okay.
difference between like the hormone changes with men versus women? Like why are men getting it not like 70s versus women
Yeah.
getting it more postmenopausal?
So for both men and women, testosterone declines over time. I know for sure I read that with women, it's like at age 35 is when it starts to decline. I imagine it's a similar age in men. And so it's just a gradual decline. And so for men, that gradual decline, well, let me step back. The testosterone has a similar effect as estrogen in that it inhibits osteoclast activity. And that means that the osteoclasts can't eat away at the bone as fast. So as you lose that hormone, the osteoclasts get to take effect more. So the testosterone is a gradual decline. The estrogen for women drops just precipitously, falls off a cliff at menopause. And so that drop doesn't happen in men for either estrogen or testosterone. So when women lose their estrogen, they lose the effect that estrogen has on the osteoclasts. So they lose that immediately. They're still losing testosterone gradually, but they've lost estrogen in a big way. Does that answer what you're asking?
So it's just that there's obviously the hormones are different.
Yeah.
One drops off just dramatically faster.
Dramatically faster.
And it happens postmenopausal.
That is the definition of it. Menopause is when you cease to produce estrogen.
And like, I guess that's a part that I found like really does not make sense to me when people are actually supposed to be getting
I know.
recommended DEXA scan.
I know.
Well, I guess, so what are you thinking about that? Because to me, it doesn't make any sense. Like
It doesn't make sense at all.
Because if you follow the recommendations from how I understand it, you actually could already have the 20% drop by the first.
You would have. Yeah. Yeah. I don't know. Like, I guess historically, I really don't think there was very much literature on how you can prevent bone loss. I don't think that there was very much out there as far as like strength training helps, exercise helps. So I guess it was just sort of like, I think actually 65 seems to be a marker for a lot of things as old. So I think we start screening for things at 65 that we don't screen for earlier. Like it's an arbitrary number. And I've heard this about other things too. Like somebody that I know that does brain research, 65 is the arbitrary cutoff for like an older brain.
Because if we're saying that the hormones are to the driver up.
Yes, 100%.
Right. And in some ways, this change is like, it's like a bone failure. It's like an organ failure. I mean, not to be dramatic, but that's what's happening. And the idea is that it's actually modifiable based off being physically active and some of these other medications that you can take. If you screen for it too late, you can have the modifiable, like your ability to actually modify and have input on the bone has been drastically reduced.
Yeah. Because even if you strength train with the goal of maintaining your bone density, not even gaining, why wouldn't you start that as early as possible so that you can maintain the most bone possible? And or if you were deciding between doing a hormone replacement therapy and not, you can't do that later in life. And if your deciding factor is bone, like you should be screened earlier.
Because I was thinking about like the philosophy of screening, obviously the area that I did research in before, is like the philosophy is that you're trying to capture somebody who doesn't present with the pathology. You're trying to capture that they have something going on that puts them at risk for whatever thing that you're seeing, and you're stratifying risk. And so if we understand that bone density is a critical thing for bone health, and we know that it's happening at a certain time, you should be screening before that happens.
Yes.
Right?
Yes.
Okay. Is there any other population that should be screening possibly earlier than what the recommendations are?
For sure, people that have had chronic use of the medications that put you at higher risk. So people who've had chemotherapy, chronic use of corticosteroids, and I think there are a few others like some of the antidepressants or anticonvulsant medications. So if you've had to use those medications a lot during life, you probably should screen earlier and be more aggressive about management. Also, for men, there's a population of men that have osteoporosis fairly young, and they're put into the idiopathic category, and maybe there's some genetic predisposition or something. So potentially, I would say too, if you had a family history, I would screen. It seems like we're still in the early days of understanding all the ways that these systems are regulated, so it doesn't hurt to screen.
But it is definitely defensible to start doing it if we believe the biggest driver is hormone changes.
Yes.
It's defensible to screen before those hormone changes actually occur.
Yes, especially if you are in a preventative mindset, which perhaps goes to the medical system is not always in a preventative mindset. It's in a treatment.
Yeah, and I think that's the big thing. So the idea first is knowing that osteoporosis, I guess, is not osteoarthritis.
That's right. Well, I think that does get mixed up sometimes. Yeah.
I feel like that's actually reasonable to understand if it's not something you deal with every day.
Right.
Hormones play a huge role in it. You might not be getting screened early enough. Like that'd be a big piece, and you just want to make sure you have it. Can you explain the DEXA scan at all? Do you understand how that works?
It's a 2D representation of the density of minerals in your bone. So it doesn't, if you wanted to understand in a 3D way, like the trabecular bone versus just the hardness of the cortical bone, I think this is how it works. If you wanted to understand the health of the trabecular bone, which is going to withstand more of the 3D forces, you'd have to do the QCT scan. So it's really just kind of a hardness measurement, not how well does your bone withstand bend.
My mentor did some of those studies.
And were they choosing a certain population of people, or they're just doing a big?
I think it was more just to show that there's differences.
Yeah.
You could have look normal, but your trabecular bone might be affected. So it's like, I think it's people maybe who come back normal and you're concerned that it's not actually normal.
Right. Yeah, I'm not sure what triggers that for people. I have in my mind, perhaps if somebody has had a insufficiency fracture, like the distal femur, that would be a time when you'd be like, oh, your T-score doesn't match up with why you're that fragile. We should do a CT scan and look at the trabecular bone and something like that. But unfortunately, it sounds like the trigger for that is an adverse event.
It's already an issue. Like you already have the problem.
Yeah. Yeah.
It's almost confirming it.
Yeah. But I don't know, like, it doesn't seem like most people should go be getting a CT scan early. Like, there's no reason to have that radiation exposure.
It's more that the DEXA scan is more than good enough.
Yes.
CT scan would be if there's a high risk that your trabecular bone.
Yes.
And then what's the trabecular bone do again?
The trabecular bone is in the ends of your long bones, and it's like just a bunch of struts. And so it withstands more of the 3D forces. So like when you're moving not so straight plane, but more bending forces, it's going to be able to withstand.
It's also like very adaptable, I think, right? Like it's like a piece that like the stress you put through and adapts.
Yes, that's why when you're young, you should stress it in a lot of different directions so that you build up a really impressive network of bone.
It's one of the reasons why you said multidirectional, multi-mode.
Yeah. That's why, when I think of kids specializing early in something like track, it's just really not necessarily great for their bones. They should be doing like soccer and basketball and track. Yeah. Like running, but in lots of directions. Yeah.
That makes sense. I wanted to pull up one question that I did get today. If your lumbar bone scan shows osteoporosis, but your hip and your femur are fine, do you need like specific stuff for the lumbar spine, or is like doing all of them going to target?
Yeah. So it seems pretty clear from literature that the jumping has the most effect on the hip. It doesn't seem to affect the lumbar spine as much. Lifting really affects the lumbar spine. So if you're thinking my lumbar spine is in an osteopenic or an osteoporotic position, then definitely lifting is where you want to go. But I would then make the case, why not optimize your hip?
Because you're showing there's some predisposition to it.
Yes, right. Yeah.
I was also thinking that if it's somebody who's already lifting, doesn't that speak to the fact that they might not be lifting enough?
Yeah.
But if
potentially so.
like you got that diagnosis.
Yeah.
Is there any way to progress the weight that you're lifting without increasing the risk of hurting yourself?
Um, well, isn't that a good question for a PT?
Because I think that there is a lot of fear because your
Yeah.
loads that you're talking about sound higher than what most people feel comfortable. Or I
Yeah.
don't know if that's is a nocebo we're giving our people, but it seems like those loads might be higher than what they're.
Yeah. So I think what we want to do here is to have a system of screening. So, like what we do in the PT world, of course, is try to catch if there's been a change that's negative in the way that your spine responds to an exercise. So, we can monitor how your mobility and strength is before a lift and then watch after a lift. And if there's been some sort of change that makes us concerned, we can say, okay, you're not ready for that lift. But, um, yeah, I think screening is a big way, and then paying attention to how you feel. Like, do you feel really tired? That's not a day to lift really heavy. Do you feel uncomfortable about one specific move because you don't feel stable or you're not sure you're feeling it work in the right place? You should talk to a coach or a PT and work on that specific lift a little more specifically. So I don't think you can ever prevent injury completely, but I think you can screen and you can try to self monitor your response and how you feel on a day.
Because I was kind of thinking about this from a few kind of couple injury standpoints of like the into people who have like a recurrent disc injury
Yeah.
with osteoporosis. I've seen that quite a bit.
Yeah.
How do they manage this recurrent injury? And I'm not sure if we actually have an answer for it. I'm not sure if there's like a protocol, which is one of my criticisms, is that weren't people in some of these studies excluded if they
Yes.
had pathology,
All of them.
which I think one of our things that we want to have is people who have active injuries being able to not only address the active injury they have, but if they have like also a bone health issue, want to be able to address it.
Yeah, so I think a lot of people obviously are going to have an injury, like, or a recurrent injury in their spine. And so I guess if you look at it as kind of like this gold standard, this is the ideal heavy lift is like so great because you get significant, like the changes reach significance statistically. But if you go to a moderate lift, you still have an increase, and it could be like a 1% increase of bone mineral density, but it doesn't reach significance, but it's still an increase in bone mineral density. It's just not as powerful as the heavy lift, but the moderate lift is a little bit easier for us to wrap our mind around when you have a recurrent injury. And as we know, like if you keep practicing and you keep working, I think that like you can progress. Your progression might just be a little bit slower. Like getting to a heavier lift instead of taking you 3 months could take you a year. But that's not bad the whole time you're lifting and you're maintaining or gaining a little bit.
I was even thinking of like, is there a seasonality to it, like
Yeah.
period of time, and then you stop, make sure the back is handling it well. I am thinking a lot about the people who have recurrent disc injuries with some of this heavier loading of like, how do you do it without triggering this cascade of things that will then actually make them more inactive?
Right. Yeah. No, I think that's a big the back component is the biggest concern, like, because that's just the most common thing we see. But nothing is ever going to be 100% prescriptive for the individual. This is just information. We know how to make bone better. And then we have to like reduce that down to what's good for the individual.
Was thinking too, things that we have that they're not going to have, will have access to your injury history. Well,
Yep.
we'll
Yep.
know what your key signs are.
Yep.
We'll be able to check myotomes. We can check for irritation. We can have it be screened based on, like you screen your back before you lift. You screen it after your heavy lifts that day. We monitor on those days. So I think there are ways for us to,
Yeah.
which we are going to. So like these are all pieces that we're gonna operationalize. But from your experience, do you think that if somebody has low back pain, does that mean they shouldn't do stuff to build their bone?
No. Yeah. Like, our coaches are too great at problem solving to just say, "Oh, I can't do it. Yeah. And besides, like, so you say you can't squat. Can you deadlift and can you overhead press? Cool. Start there. I'm sure there's a way to do a squat that's maybe not heavy, but it's a building block to being able to lift heavier. Because also, like these studies, they do the deadlift, squat, overhead press. It's kind of like the meat of like each of the moderate and heavy lifting. But there's nothing that shows just doing squats or just doing deadlifts. Like none of this is like written in stone. We know how to do it. This is just indicators of like generally, this is how you create new bone or maintain healthy bone. Within that, we just work with what we have. Yeah.
I think to me, that part makes a ton of sense. And I think it really, I got a couple emails
Oh,
on that where I think people have some of the reasons they aren't lifting more is being afraid of
yeah.
a setback. And I was also kind of wondering, so if when they go up in higher load, do you think that there's any loss of bone benefit if they have a brace on?
Oh, I was going to bring that up. No. Do you? I cannot imagine how that would be. What would a brace do? Like, there's no way it's absorbing load. It's only letting your muscles work more efficiently.
Brain stiffness, maybe
Yeah.
reducing shear, some of the things I think
Yeah.
actually are the drivers of when people hurt their disc.
Yeah.
I don't see how it reduces load. I mean, it was one of the things where
Well,
I'm gonna look up, but I couldn't find anything
yeah.
that said it reduced bone load.
If we go back to those studies that were they like sponsored by Volvo, there was a set of studies, right, that they like to quote, but they were really clear that if you wear a brace and you're sedentary, you can lose strength. If you wear a brace and you do exercise, you will get stronger. It was very clear that the brace is beneficial.
I think that I always think back. I think it was a Stuart McGill study where it showed too. There's a proprioceptive effect from bracing.
Yeah.
It doesn't reduce core activation or anything
Yeah.
like that, but it actually gives you proprioception.
Yeah.
So it tells you where you are in space. So
Right.
I think that those are things that I think we'll want to consider. But if somebody's thinking about doing the loading, and they actively hurt,
Hmm.
like that makes no sense.
Right.
If we get them symptom free, and then there's going to be pathways for us to get load in a safe way.
Right.
How
Yeah.
about with the hip? Is there anything kind of similar to that? Do you have anything with the hip where you're afraid of producing the
Mm.
load that they like what the femoral neck needs or the femur shaft or anything like that?
Yeah, I think that like from what we see in a different population of stress fractures, what we know is that nutrition has to be on board. You have to be taking in the right kind of, it's not calories, it's the right nutrition to keep your bone healthy. I think that might be more of a fear for me because you're doing impact and the femoral neck and the femoral shaft are more at risk, I think, for fractures when you're in a low energy state. So there's that. But I think with the jumping, I think it would be ridiculous for most people to do like some sort of really hard land day one, but you're in control. The heel drops are pretty jarring. If you do single leg hops, you're in control of how hard you land, right? Like, so if you land a little softer and then gradually you start landing a little harder, cool. But I think if it feels bad or it feels uncontrolled, you can change it. So that's the kind of fun thing about the jumping.
The things that I think I was most nervous about, things that we'll be able to do, like hip screen and knee screen, are definitely my biggest concern is that we're going to cause a traumatic synovitis. A traumatic synovitis being just to basically jam your joint. And I'm really interested to see if we just manage joint irritation at those two places. I couldn't think of another issue that I'm really concerned about. Maybe low back, but if we make sure that they don't get swelling, and literally you're not going to be hurting muscle.
Yeah, exactly. It's not, yeah, I've been thinking about that. It's like, it's potentially a pinch, right? Situation, but also it's not high reps. So you really are doing like less than 25 jumps potentially. So that's actually not that big. So again, it's progressive and it gives us a chance to screen and see how you do. It's just so different that I think we all have like a little bit of a fear response. But I am actually just kind of trying to keep myself open to like, that's the PT in me that has the fear response. And I don't think that that's appropriate. I think we should be able to jump.
And to be honest,
Yeah.
that's why it's like it takes a team like that.
Yeah.
Having a coach who doesn't have some of that.
Yeah.
It's like I always say that if you're a good PT, you're a little bit afraid to have dangerous.
Everything.
Yeah.
I'm afraid of everything.
If there is somebody who is nervous to try it, well, I think let's start there. If somebody's nervous to try it, what would you tell those people? If they have osteoporosis or osteopenia, what would you want them to know?
Well, first of all, we've got our eyes on you, so we're not going to let you do anything totally crazy. We're happy to screen. We're happy to set up one-on-ones with coaches. We're happy to set up PT appointments. If you don't understand how you'll know if you're having a negative response, let's figure it out. Like I don't know for every person, I don't know what's going to show up until we do it. And then we just have a way to test for it and teach you how to test for, are you having a positive or negative response?
Okay. And so is there anything else that you want to make sure anybody who's interested knows before I close it up?
I think all this information is really new and exciting, and there are a lot of questions around it. And I don't think that any one of us has all of the answers. There's no one study that lays out a very specific answer for everybody. I think it's just a matter of, like you said, we have a team. We're all on the same team. The team wants us all to have a good bone health. We'll make modifications as needed, and yeah, just kind of work with whatever happens. It can be a bit of a fluid situation, even though I laid out these sort of structures that were really regimented. It doesn't have to look like that for everybody. And it can look like that for 5 months, and then you have a month or two where you're just exhausted and life is really hard and you need to back off, and that's fine. Can pick it back up.
I think that's the part that I'm most excited about is that it's going to be one of the first things that I've seen where it's been operationalized to this level outside of a research study, and we're not excluding people. Like I
Yeah.
think that part I'm really excited about because we'll see what does it really look like in a group who has normal injury risk.
It's fun.
Yeah.
We'll see.
We'll see.
Yeah, I don't know if I had a prediction on that. Yeah, I think I don't have fear around the injury part, because I think we do have such a good team to help manage it and make modifications as needed. I think it'll be fun. I agree with you too. Like the studies are so clinical, if you will, like the populations are so specific, and it's really fun to put it into the real world. It's like really fun to think about the fact that you could make a change in your own bone density just by choosing to show up 2 or 3 times a week.
If you are interested in learning more about SPC, our osteoporosis program, or how to stay active and healthy, please let us know.
Wow.